Ladies and gentlemen, welcome to this session about value-based healthcare. I had the privilege yesterday of standing in the back of this room, listening to the excellent presentations in the opening ceremony. And I made three reflections from the presentations given. Three messages that came across throughout many of the presentations. The first one was the challenge of growing healthcare costs and our failure to effectively contain the cost increase we're seeing and the implication that has for many other societies. The second one was the dramatic growth in non-communicable diseases we're seeing. And Margaret Chan made a strong point of that we need to have novel integrative approaches to handle this epidemic we're seeing, but also that we need to have a global approach. We need to learn from each other as we see this development happening. And the third message, which was also a message that Margaret Chan conveyed, was the unanimous decision of the United Nations to push for universal health coverage. But Victor Zhao, the head of the American Academy of Medical Science, made a strong point that it's not only a matter of access, it's also a matter of quality. Are we providing patients around the world with good quality care and not only care? The productivity challenge is ubiquitous in healthcare. For many years, we have tried to find ways, often taken from manufacturing industry, to make healthcare more productive. We have focused extensively on cost control. We have managed components of this complex healthcare system through unit pricing, fee-for-service models, and often in a way we have not considered the integration, the holistic answers to it. We find that because the financials remain challenging and cost grows as fast as it does, we're seeing more and more control over clinical practice. We're finding more and more KPIs being imposed on clinicians around the world, and their autonomy is being limited in the aspiration of holding down spend. We're also finding that quality is being discussed, but quality is often defined as avoid making mistakes, what we often refer to as patient safety, or it's defined as compliance to guidelines. If you do what the guideline tells you to do, you have high quality care, without necessarily knowing that the end result is good or bad. What we also find is in the production-focused healthcare systems we have, there's less and less room for clinical research. The time of clinicians to spend on research is decreasing in many of our big academic medical centers. And linked to this is a slow adoption of new technologies. It is challenging to get innovations to the patients. And what we call translational science has typically been quite challenging. What we need is to challenge ourselves. Is what we see, the challenges we're facing, an inevitable consequence of the way medicine is? Is it just going to get worse? And we just need to turn the thumbscrews even harder? Or can we think differently about this? The view of the panel today is we can and we must think differently about the challenges of healthcare. We need to understand the impact of our efforts. Are the treatments we're given, is the organization we have leading to better outcomes for the patients? We need to have a healthcare which, in the true sense of the word, is patient-centric. We need to think of payment not as incremental payment for components of the system, but bundled payment for someone taking responsibility for a larger part of the care chain. We need to define shared goals for all the stakeholders in the system so that they jointly define the optimal way of treating a patient, not primary care versus secondary care versus tertiary care, but how do we optimize along the care chain? If we define the outcomes that matter to patient and we understand the resources needed for that patient group, we can actually engage clinical staff in solving the problem of healthcare, namely meaningful healthcare productivity. And a healthcare system that focuses on outcomes is also a healthcare system that will integrate clinical research in its normal practice. Translational science will not have to be pushed on clinicians. They will pull for it. They will want innovation. They will want to be part of improving care for the patient groups. So what we mean by value-based healthcare is that we need to measure outcomes that matter to patients for each one of the major patient groups. But of course, we need to understand the cost that the resources we need to achieve those outcomes and the ratio between what we're achieving in outcomes and the resources needed to achieve those outcomes. That's what we mean by value. That's how we define value. And that's the sense of the word that we'll use in the discussion today. Now, many have studied geographic variation in healthcare. And many of you have seen the work, excellent work that Dartmouth and others have done. For instance, looking at the variation in healthcare costs in the United States and elsewhere. Variation in healthcare spend is quite dramatic depending on where you live in the United States, as an example. But few studies have looked at the variation in outcomes, which is really what matters to patients. We've recently completed a study which we're submitting this week, and therefore, since this presentation is on the web, I can't show the detailed data, but I can share you some of the key conclusions. What we find in this study is shocking variation in outcomes. If you look at, for instance, inpatient mortality for heart attack, it's just less than 5-fold differences between the top decile and the 9th decile in the United States. If you look at some other metrics, so for instance, the pressure ulcer rate, patients laying without being turned around rapidly enough, the pressure ulcer rate is 22-fold difference between the worst decile, the best decile, and the 9th decile. That's a huge difference. And if you look at central venous catheter infection, there's more than 20 times difference between the top decile and 9th decile. Ladies and gentlemen, if we can't address that variation in healthcare that we see in the normal landscape, we will never reach a significant improvement in healthcare productivity. Now, you may say that variation is large and it's shocking, but it's probably very hard to do something about it. Our view is you can. And one great example is from one of our panelists, the Martini Clinic in Hamburg. The Martini Clinic started in 1992 a disease registry to measure outcomes that matter to patients for prostate cancer patients. They have since built the world's largest database on outcomes data for prostate cancer and have focused the entire team on outcomes measurement. And when it comes to mortality, the survival rate for the Martini Clinic is equivalent to that of other clinics or other surgical units in Germany. Roughly 95% patients survive 5 years or longer. But other important metrics for patients are, for instance, erectile dysfunction, often a negative consequence of prostate cancer surgery. You have less than half the risk of that side effect at Martini than you do in the average German hospital. And even worse, if you look at incontinence, there is a 7-fold difference. So your risk of being incontinent is 7 times higher if you go to the average hospital than if you go to the Martini Clinic. Those differences are not marginal, those are massive, and they mean an enormous amount for patients. And not only do they mean a lot for patients, they mean a lot for payers, because all these patients need extensive medical attention because of the side effects. So the choice where you go makes an awful lot of difference. Now, how does this work? So measurement of outcomes and making the data transparent, if clinicians agree the metrics are right and that the data is of high quality, leads to a great interest in the variation. Why are some so much better than we are? How can we learn from them? How can we improve? The competitiveness of the profession is an important driver to drive improvement. And we've seen in many examples around the world that outcomes measurement and outcomes transparency leads to improved outcomes. It leads to reduced variation, so equitable care. to a larger extent. You also find often, in most cases, a significant reduction in the cost of care because you do it right from the start. And finally, you get an inspiration among the clinical teams for continuous improvement. Today's panel, we have 6 strong leaders who, with different perspectives, will describe to you how they see this development. The first speaker will be Professor Melvin Samsom, who is the CEO of the Karolinska University Hospital. He will describe to you what he means by patient centricity and how he is transforming the organization he leads to become a value-based academic medical center. The next speaker is Hartwig, Huland, who is the mastermind behind the Martini Clinic in Hamburg. He will describe to you how important it is to listen to the patient as part of your assessment, and also how he has integrated the outcome measurement to become a central part of the institution he has led, not only to create clinical excellence, but also to create a leading center for research on prostate cancer. The third speaker will take us from a center of excellence to look at a national network. Jonas Oldgren leads Uppsala Clinical Research Center, where they have leveraged measurement of outcomes on a national level to do clinical trials in normal patients. So randomizing patients in the normal population to one treatment arm or the other, and thereby doing larger studies, cheaper studies, and faster studies, which are in fact also in many cases more relevant to the population. The New England Journal of Medicine called this disruptive research when the paper was published just more than a year ago. With Christina Rångemark, we will move to the global arena. Christina leads an organization called ICGC, the International Consortium for Health Outcome Measurement. ICGC is a not-for-profit organization seeking to develop global standards for outcome measurement. What if we were measuring heart attack outcomes the same way in Calcutta, in New York, and in Berlin? We could compare and find best practice irrespective of where in the world it took place. We could learn an awful lot if we had a global measurement as standards. And Christina leads that work, and we'll be talking about that. Now, many of the examples about value-based healthcare come from the richer countries. And so a key question is this as applicable for developing countries? Could potentially developing countries leapfrog all the mistakes we've made in the West, just as they did with mobile phones, avoiding landlines, go direct? The next speaker, or the next panelist, Mark Dybul, is the executive director of the Global Fund fighting against AIDS, malaria, and TB. And he will share with you how his organization is taking very exciting initiatives in this space to use outcome measurement as a means of driving improvement of clinical quality in developing countries. Now, the first 5 panelists will primarily talk about clinical practice. How can we improve clinical practice through this approach? So another question is, what does this mean to the innovation industry? The pharmaceutical companies, the medtech companies who bring new innovative products to the market. Is value-based healthcare a threat to them? Or maybe an opportunity? Or maybe even a prerequisite for success? Therefore, the final panelist is Joe Jimenez, who is the CEO of Novartis, the world's largest pharmaceutical company, and is also the president of EFPIA, the European Pharmaceutical Industry Association. And he will share the industry view on value-based healthcare. With that, ladies and gentlemen, I'd like to introduce to you Professor Melvin Samsom.
Well, good afternoon, ladies and gentlemen. And thank you, Stefan. I was very grateful about your invitation, up to the point that you mentioned that I had to explain it in 5 minutes, our transformational journey. So I will make an attempt. Only 3 or 4 slides, and that will really compromise the talk that I would like to give, but gives you a clear idea on where we stand at this point in time. I think that when we talk about the changes in healthcare, we all agree that we need to do so. But how do you explain this to your co-workers, to the doctors and the nurses? And I typically talk about the major challenges and the problem, just to go back again to the why of the organization and to explain why it is what we currently see. I think that over the last 2 or 3 decades, we have seen an enormous step in increase in knowledge about medical developments, in improvement of diagnostics, in improvement of treatments. If you look back at the way we treat patients nowadays and compare it to 20 years ago, I think we all agree that we made a major step in this time. And at the same time, we now have a period that it's not as much the medical knowledge that prevents the next step that we're currently doing, but it's the fragmentation in the system that we have been building up. We have been building up a system with a lot of silos within hospitals, but also between healthcare providers. And that really limits, at this point in time, the value that we want to add to our patients. So lack of a holistic perspective is a very important topic when we talk about the changes in the healthcare system. A second part is, where Stefan already touched a little bit upon, is the huge variation that we see in practice and quality. There's a lot of research out, and I would recommend you to read about that. It's increasing rapidly. We really can see now that there is a huge variation in practice. That is that how we diagnose a disease or start the treatment varies a lot between different care providers and even within hospitals, within different departments. And in addition to that, the clinical outcome of what we do, how we treat our patients, is quite astonishing. If you study for instance, the outcome of cancer treatment in 5-year survival or 2-year survival, you can see very large differences in hospitals that are very near to each other, which is, I think, unacceptable. And the third point reflects, of course, to the recurrent issues that we have in costs. We have been facing that for more than 10 years, 15 years maybe, and we tried to improve our system, but I think that looking back, we quite are now in a period that we can see that we failed to really change our system in such a way that we can get a grip on the increase in costs. So I think that we need to act and organize ourselves in new ways. And I will explain a little bit on what we're currently doing at Karolinska to really set up the new basis for the model that we're currently talking about. Value, added value, is really the thing that we need to do in healthcare. Although when I talk to my doctors and nurses, they will explain to you that they are doing this on a daily basis. When you analyze it and dissect it out and really come to the core of what added value is for our patients, we know that there are very often differences between what we think is important for our patients and what patients think is important to them. In addition to that, I think it's very hard to have a complete overview of the costs connected to the clinical pathway of a patient throughout our healthcare system. So in order to assess the value, we need to get more grip on outcomes that really matters to patients and the costs per treatment. We started out in analyzing the number of patients groups we see at Karolinska. At the moment, we know that we see about 290 different patient groups. And we are now asking our multi-professional and multidisciplinary teams to redesign the flow of the patient throughout the healthcare system together with patients. And of course, we have multiple clinical pathways that have been set for many years. But reviewing them and rebuilding them together with patients gives really new insights in where we are missing connections and where we see fragmentation that is really resulting in lower value than we would like to expect. So we're rebuilding these patient flows, and in order to do so, we appointed a patient flow captain, one person who is responsible for overseeing the complete patient flow throughout the hospital and throughout the healthcare system, thereby bypassing the original clinical division that we have and bypassing the different groups that we now separate the hospital in. So take, for instance, a patient with breast cancer who will see a surgeon a radiologist, a medical oncologist, a radiotherapist, and a plastic surgeon that now work in different clinics will all be combined as a multi-professional team within one patient flow. And the new line manager will be a patient flow captain. And adding the different patient flows, we will have themes. And in our current design, we look upon about 7 themes, varying from children and women's health to theme about the elderly patient. And they will contain the 290 patient groups that we see at Karolinska, integrating in every group, in every patient flow, education and research to a large extent. Vertically, you see the function areas. So where we see that the patient cross functions like lab and functions like radiology. And in our new design, the patient flow is leading in this. And the function areas will adapt as much as possible in order to add value to our patients. In a year from now, we will move to a new building, one of the largest university hospital buildings that's currently being built in Europe. And there we will start working in this thematic way. It's set up in such a way that we can leave our current structure, start operating in a new model according to the values that I just tried to describe, with patient flows designed by patients and by multi-professionals, multidisciplinary professionals, in order to have a good overview on the value that we create. Along the way, we have created new KPIs, much less KPIs than we have today, and created dashboards in order to allow the patient flow captains to oversee the current outcome and the current costs of the patient groups. And in that way, we see that we're moving forward by redesigning our organizational structure and using the new environment as a large catalytic engine, adding value for our patients together with our patients. Thank you.
No, it's in there. It's in.
We wait for my presentation.
No, it's in there, so just continue. All the presentations are in the same file, so we should just keep going. No, I've given one presentation. Everything is in one presentation.
But it's on the stick also.
Everything is in one presentation, so please do not change.
Okay. First of all, calm down. Thanks, Stefan, Larsson, for the invitation. It's a big honor to be here and a big pleasure to be here. I will talk about standardized PROM. I tell you later on what it means for science. Very important for science, and quality control. You allow me to give 2 slides from the Martini Clinic. The Martini Clinic is a specialized clinic on one disease, prostate cancer. It's situated on the campus of the university. It belongs to the university. It is in a separate building from the main building. It has its own building. But most important, it covers every aspect of this specific disease, including every aspect of diagnosis, local therapy, robot-assisted, traditional open, any type of radiotherapy, metastatic, psycho-oncology, lifestyle study groups, clinical basic science research, everything under one roof. Michael Porter would call it an IPU, an integrated practice unit. Sorry to give you this success slide. Surgeons used to define their success with the number of operations they do, justified or not. And we do, in the meantime, now 2,200 radical prostatectomy. I roughly can say every 10th radical prostatectomy in Germany is done at our institution. And with this, we are the world's largest, followed by Mayo Clinic and Johns Hopkins, doing about 1,200 radical prostatectomy a year. The main reason, from my aspect, besides the fact that we are specialized on one disease, for this success is our database. That's why I'm presenting this success rate. And I started it in 92. We got on a yearly basis all the information of our patients and their outcome. And as you can see, we have now more than 20,000 patients in our database. We have a follow-up rate of 90%, but if you look very critical only to those who had complete follow-up over all these 22 years, then it is respectable 75.5%. And it's not easy to start a database. I could give a 1-hour presentation how difficult it was to start. I will name only 2 difficulties. As you know, and this is true for many countries in the world, the follow-up of the patients is not in the hospital. It's outside the hospital, done very well by private offices, specialists in private practice. So how to get the data? You cannot motivate your staff, your residents, to contact 20,000 people late in the afternoon when they want to go home to get the data. There's one wonderful method to get this data. It is a golden bullet. It's called PROM, Patient-Reported Outcome Measure. Patient do it. We learn from the patient, and they love to do it. That's why we have such a high response rate. And just to give you an example, after radical prostatectomy or radiation therapy or active surveillance, whatever you do, you want to know the function. And in this case, the outcome, the instruments are certainly different in every different disease. In this case of localized prostatacarcinoma, we used something called EPIC-26, which is an international validated and accepted questionnaire. It needs to be validated. It has 26 questions in 5 domains: urinary function, bowel function, erectile function, and hormone therapy. And the patients also tell us the oncologic outcome in 7 questions, standardized questions, and complications only after 6 months. Again, standardized using validated questionnaires, the Clavin-Dindo classification. And before I tell you how important it is for value-based healthcare, if you do that in your clinic, you have a lot of benefit and fun. Out of this database, we are very, very active in clinical science. Believe it or not, this little clinic does 50 to 70 publications a year, representing 300 to 400 impact points per year. And not every publication, but most of the publications mean that we are leading forward what we know and how we treat this specific disease. It is a database for basic science. There's a very exciting activity going on internationally. Most of you will know, called the ICGC, the International Cancer Genome Consortium, to make it short. The idea is to get the genome sequences, completely sequences in 50 most common malignant diseases. Each malignant disease, at least 500 samples. And it's expensive, of course. And Germany contributes with 3 projects: kidney, child brain tumor, lymphoma, and prostate cancer with our clinic. And the only reason why we are involved and get supported from the government because of the database. And this is important. We have a faculty, 10 surgeons. I don't have put the names on it, just the numbers, but I outed myself for the number 4, that's me. And every half year, we sit together and our biostatistician prepares about 50 to 60 slides about our results. 50 to 60 because they need to be risk adapted. You know, the one might have other patients than the other. And I give you only one example, and again, I could give you much more examples. We get a letter 1 week from our patients about their continence when 1 week after the catheter is removed. And a good figure would be 30-40%, the green part of the bars. I was pretty good with 70% and was always proud of it. But someday, number 7 was better than I. I couldn't fire him. I looked at him, what he is doing, and he changed our technique, and very smart variation. I don't want to go in details now. And then we adapted it all, and as you can see, suddenly we all jumped up from 88% complete continence at 1 year level, not at 1 week, 1 year level, to 94, 92, 93% level. These are the figures of all our faculty members. So we learn from each other. And the average, as we heard before, continence rate 1 year after radical prostatectomy in Germany is in the range of 57%. The database can be used for that. Variations in outcome. We have heard it again and again today. And this is only a small part of a big list which I got from the Harvard people, from Mike Reporter and his colleagues. And if we name here 9-time variation from between the best and the worst after radical prostatectomy in Netherlands, the same is true for England, Denmark, Germany certainly, and others. And the real bad part is not only, depressing part is not only this. The real depressing part is that the doctors don't know about it. The clinicians don't know it. So it's even worse. Patients who have this certain disease have no chance, 0 chance to get that information, where the outcome is here, there, and there. That's depressing. Of course, we do a lot of effort. You read every week in the newspaper that quality control. But if you look more carefully, most of it is done to improve the management, the process management. And this is the basis for certification. It is controlled by audits. With process management means they look, do they do thrombosis, prophylaxis, hygiene effort, and so forth. But it is a compliment to the Harvard people, especially the pioneer Mike Reporter, to focus our view on outcome measurement are the powerful lever to unlock a value-based healthcare system, to include that, to improve quality and to solve the problem of variations in outcome. And that's why he, together with Boston Consulting, with Stefan Larsson and Karolinska, started the non-profit organization ICGC, International Consortium of Health Outcome Measurement. We will hear in a minute more about it, to initiate internationally minimal standard sets for outcome for each disease. And I had the pleasure to lead the 4th project about localized prostate carcinoma. On top you see that we have been a group of 28 persons from 9 countries, urologists, radiotherapists, experts in registries, and patient representatives. We learned a lot of them and brought up a manual telling what should be documented on outcome in this specific disease. And it was published recently in the March issue of the European Urology. My last slide. Quality improvement in future, not only by process management control, also by standardized, risk-adapted, transparent, international comparable outcome measurement using PROM. Let's learn from the patient. An investment is necessary for outcome measurement, but it pays off. And this is my message here today. It is intellectual fun. We learn from our patients, and it improves quality. Thank you.
So first of all, I would like to thank the organizers and especially Stefan for inviting me. It's my pleasure and privilege to discuss with you healthcare or clinical quality registers as a basis for outcome measurements and also for clinical research. May I have my first slide, please? Thank you. I come from Uppsala University and the Uppsala Clinical Research Center. We are the largest non-profit academic research organization in Sweden. We conduct clinical trials within Scandinavia and in collaboration in global clinical trials. We manage major national clinical health care quality registers. We have more than 20 national registers at our site, and we also perform outcome research. Our quality registers range from in vitro fertilization to dementia, so it covers the life spectrum. Perhaps the most well-known, at least the most international well-known registry is the Sweetheart Registry, which covers ischemic heart disease and cardiovascular interventions in Sweden. So all 73 hospitals in Sweden with coronary care units, all 30 cath PCI labs, all 7 heart surgery units provide data to this quality register. So we have 100% coverage of all patients entering coronary care units for a suspicion of myocardial infarction. We also have secondary prevention treatments in the registry and follow-up. So we have more than 200 variables in each patient, demographic, procedural, and outcome measures. And when we look at the healthcare files and the registered data, there's a 95-96% agreement between the original data and what we have in the quality register. So we continuously monitor this. This can then be used to benchmark hospitals within Sweden. I guess you can't read the names of the hospitals on the left side panel, but it's not important at this time point. So we have a quality index, 9 points at maximum, for procedural measurements, both in acute care and in secondary prevention. And this is displayed publicly since 2007. It's open, it's fully transparent for healthcare personnel, for patients, for stakeholders in healthcare, to see which hospital has the best quality index and which has the poorest quality index. And of course, physicians always say, well, my patients are different than patients at other hospitals. And there are, of course, differences between small countryside hospitals and university hospitals. So on the top right panel, we provide observed versus predicted mortality. So the predicted mortality in each hospital is based on the case mix in that hospital compared to the standard in Sweden. And it's obvious that the hospitals with the highest quality index, they are usually on the left side of the panel with lower observed versus predicted mortality. And patients on the left panel at the bottom with poor quality indices, they have higher observed mortality than predicted mortality. So we can benchmark hospitals between each other. We can also look at this between countries. On the lower right panel, you have a comparison between myocardial infarction care in the UK and in Sweden. We think that UK is a great country with well-developed healthcare. The mortality rate is 30% higher in UK than in Sweden. It's 30% higher. And one of the reasons is that it's a large dispersion between the hospitals in the UK. We also conduct randomized clinical trials. We try to do them as pragmatic as possible. And to do a randomized trial, to compare treatment A versus treatment B, or an old treatment versus a new treatment, is the golden standard in medical research. And it distinguishes confounding by the randomization. The weaknesses of randomized clinical trials are that we all often have highly selected populations due to narrow inclusion and exclusion criteria in a clinical trial. We often perform these trials in selected specialized study centers and sometimes or often have surrogate endpoints instead of hard outcomes like mortality or morbidity. It takes a long time to plan and to complete traditional randomized clinical trials, and they are extremely expensive. So only studies at economic interest, for instance, from the industry, will be performed. Or, as Dr. Rob Califf, previously head of Duke Clinical Research Institute and now commissioner at the FDA, says, current clinical trials are too slow, too expensive, not reliable, and not designed to answer the important questions. And we started thinking about that at UCR in Uppsala. If we have our clinical quality registers, where we register everything about our patients, and because of the personal identification numbers, we can also merge our data from the registers with other registers like the mortality register or the patient administrative register with all hospital admissions throughout Sweden. Can we use these clinical registers to perform randomized clinical trials? And that is what we have done for the last few years now. So we call it register-based randomized clinical trials. This is a busy slide. I will try to guide you through it. So randomized clinical trials within a clinical register facilitates identification of study subjects, randomization, collection of baseline and procedure characteristics, and we can sometimes also use it for clinical endpoints. Otherwise, we merge with other registers. One example, still the best known, is the TASTE study, thrombus aspiration in ST elevation myocardial infarction. We have a small SIIMark device. When patient comes in the middle of the night or whenever with a myocardial infarction, we can suck out the blood clot in the coronary artery. And we did a controlled trial to test this device compared to standard treatment. In the top left panel, you have the blue line, all acute PCIs, all acute coronary interventions performed in Scandinavia during 2.5 years. Of those, more than 60% of the patients, 24/7, were enrolled in the trial. Usually, in a traditional trial, perhaps 5 or at maximum 10% of the population is enrolled. So we have a good population. It's a representative population of the standard care. We have 100% follow-up because all patients are in the register. So even those patients not randomized in the trial are followed up. By this, if you look at the left panel, bottom left panel, the TASTE study was 7 times larger than the next largest study. The second largest study was the TAPAS trial, which has shown a 50% reduction in mortality by this device. It was a small, single-center trial, not powered to show mortality differences, but the mortality was 50% lower by the device. And look at the upper right panel. Mortality in the TASTE trial, 7 times larger. There's no effect at all on mortality. That's nothing. It's neutral. Later on, a traditional randomized clinical trial called the TOTAL trial did the same. There was no difference in that trial either. The cost of the TOTAL trial was approximately 30 times of the TASTE trial. 30 times more expensive to show the same result. And this is, I guess, why Mike Lauer at NIH wrote a perspective in New England Journal of Medicine saying that the randomized register trial is the next disruptive technology in clinical research. And that is why we are now currently conducting a handful of register-based clinical trials in vascular surgery, in anticoagulation, and perhaps one of the most anticipated. We test the most used pharmaceutical drug in myocardial infarction treatment throughout the world, which is oxygen. Oxygen is recommended in every guideline in the world. It's used in every part of the world. There are few studies, and they all show an indication of increased mortality by oxygen. It's increased mortality. We're now performing a large-scale clinical trial. We have more than 6,000 randomized patients to oxygen or to air. And we hope to see the results in 2017. So I think this is the future for clinical research. Thank you very much.
Thank you very much for the invitation. And in order to put ICHOM in context, let me just take a couple of steps back and for a minute reflect on what we have heard in this panel so far. about healthcare systems worldwide struggling with uneven quality and increasing costs, and the future that will demand a demonstration of better value, either via improved outcomes or lower costs, or maybe both. But how will we be able to demonstrate better value if we don't have the full picture of the result for the patients? And to be honest, we don't have the full picture today, because most measures and metrics used are still structural metrics or process measures, very few being patient outcomes or patient-reported. And they are difficult to compare and share best practices from because they are locally defined. We have already heard in this panel from Professor Huland that when he led the opening of a new prostate cancer center, he wanted to deliver the best care in the world for the patients. And he defined best in terms of what mattered the most to patients: rates of cancer recurrence, incontinence, erectile dysfunction. Things we all know are important, but actually very few measured, and specifically so at that time. So to start creating this full picture, in order to be able to demonstrate better value, we need to start measure and start report meaningful outcomes globally. If we do so, how far couldn't we come? So in order to support this meaningful outcome measure, ICHOM, which is the shortening of International Consortium for Health Outcome Measurement, was co-founded in late 2012 by Professor Michael Porter's Institute of Strategy and Competitiveness at Harvard Business School, the Boston Consulting Group, and the Karolinska Institute. The mission of ICHOM being unlocking the potential of value-based healthcare by defining global standard sets of outcome measures that really matters to patients for the most relevant medical conditions, and not only defining, but also driving adoption and reporting of these measures worldwide. Today, we already have 12 standard sets covering 35% of the disease burden based on year lost due to disease defined. You can see them on the left side of this screen here. 5 out of the first 12 have already been published in peer-reviewed journals, and the other 7 are all submitted for publication. In the middle, you see the 9 currently ongoing developments of global standard sets for this year and early next year. And on the right-hand side, you see the 17 currently discussed standard sets that fill the pipeline for the years to come. And we are very happy to note an increasing amount of proposals for new global standard sets to be defined. Defining a global standard set is project-led by ICHOM and brings together globally leading clinicians, registry leaders, and patient representatives for a period of approximately 8 months. Based on an extensive review of literature, the group defines the outcome domains and the risk factor domains to be included in the minimal standard set defined globally. And the final product is a reference guide, which is a printed reference guide where you can find all the definitions of the outcomes and the risk factors and how to measure them. This reference guide can also be downloaded from the ICHOM website for free and be able to start in your own setting, testing them out. As of today, almost close to 400 participants representing 28 different countries have been involved in this work. and the ISOM standards are the only global standard sets currently available. Being a non-profit organization, we are heavily dependent on our strategic alliance partners and our sponsors. And as you can see on this slide, we are happy to have many engaged partners and sponsors. Professional organizations, patient organizations, leading private and public providers, and private and public payers. And we do not only notice an increasing demand for new global standard sets to be developed, but we are also excited about the increasing interest to implement the sets worldwide. Examples as Stanford Healthcare implementing the low back pain, the Irish prostate cancer outcomes research implementing both localized and advanced prostate cancer, the Mayo Clinic implementing Parkinson's disease, the Melvin NHS Wales implementing Parkinson's disease, the Massachusetts General Hospital implementing coronary artery disease and stroke, Boston Children's Hospital and Great Ormond Street Hospital implementing the cleft lip and palate, and Aravin Eye Care System implementing cataract, and Ramsay Healthcare Australia implementing depression and anxiety. So all in all, almost 200 organizations implementing or planning to implement one or more of the global standard sets. And our next step will be to launch pilots for the benchmark and in order to be able to benchmark, to motivate clinicians to compare their performance and learn from each other. And this will disseminate innovations from one individual or team to another, and lead to a much more comprehensive focus on the interaction between the outcomes and the processes, and help us better understand which activities and services provided really provide value, and which ones can be reduced or even eliminated without compromising outcomes. And with this increased transparency and focus on patient outcomes, patients can also be much more participating and co-productive in their own medical condition and the treatment of this condition. And payers, of course, will have a better understanding of the results achieved for the resources spent. So in summary, outcomes are in the center of delivering better value. And if we would like to navigate away from uneven quality and increasing cost, we need to start by globally defining, measuring, and reporting outcomes that really matter to patients for the most relevant medical condition. And ICGC is proud to be a part of and be a catalyst of this important work. Thank you.
If it's okay, I'm actually going to speak from here because I don't have slides. Joe and I were actually told not to have slides, so we don't have them. So it's great to be part of this panel because it's a demonstration of the need to think differently. Because if we think the same way, we're going to end up with the same result. You can't change what you do if you don't change the way you think, and this panel is a demonstration of that. Although, to be honest, as a man getting older, the best thing about this is learning about the Martini Institute, so when I have the inevitable prostate problems, I know where to go. Universal health coverage is one of those new ways of thinking. And it's been mentioned that, and this is very clear in the Sustainable Development Goals, that coverage does not just mean service. It actually means quality service for outcomes. And that's an important shift that we're seeing. As we've looked at it, we've been focused on what we're terming resilient and sustainable systems for health. We've often talked about health system strengthening, but if you are focused on a system as your outcome, that's what you'll get. If you're focused on health, you're more likely to build the systems that are necessary to actually provide health. And a few components of that that are very relevant here is, one, engaging the community. If we see a health system as ending at a health clinic, we will fail. As a former minister of health, and he can probably say this because he's a former minister of health from a very large African country, said, I wasn't a minister of health, I was a minister of public hospitals. Because health gets into the community. Health is about prevention. Health is about service provision in a high-quality way. It's far more than a clinic. And so we need to see the health system and health in a much broader context. And one way to do that is to focus on outcomes. And that's one of the things we're talking about here, on outcomes that get deep into the community. And very relevant for this conversation is really how you use data and who uses data. A big part of the conversation post-Ebola is on health surveillance. And that's great. We need surveillance. But surveillance is how someone in a village reports to a center, that reports to a hospital, that reports to a region, that reports to the country, that reports to globally, and then you have a response that goes back down that chain. Imagine if your first responders to a fire had to get approval from the mayor or the president or some global organization to put a fire out. The world would have burned down a long time ago. And that's basically what will happen in health if we expect data to be used only up the chain. But that doesn't mean the data are the same. So then how do we develop a data system that's responsive to and collected by a community healthcare worker that will be important for how that community health worker responds, how a doctor responds, how a regional health director responds, how a country responds, how the world responds. That type of data management system has to be built on quality and quality of programs. And it very much focuses on the approach that's being talked about here, a patient-centered approach, actually a person-centered approach if you're going to deal with prevention. And that is something we all, I think, actively need to build. We have been working actually with BCG in a few countries to look for those positive deviants, places where communities are providing health care. We looked at TASO, a community-based organization in Uganda, that by doing simple things achieved a much higher result than the similar organizations nearby. So we went to look why. Those are positive deviants. Why do some centers do better than others? And we were looking at retention. It's not because of better guidelines. It's not because of better health indicators. They all have the same ones. It's because they had drugs in stock and everyone in the community knew it. It's because their waiting times cut down to a very short period of time. It's because they had a waiting room that someone wanted to sit in. And we focus on those pieces, and then we can use them to improve quality and have a quality assurance approach. But first you have to understand why something works, and not the 5,000 reasons something could work, but what's actually working on the ground. I showed some data this morning from the Minister of Health in Ethiopia and the Minister of Health in Rwanda that shows how they use data to improve their systems. Our estimates are that if we use this approach just for this one intervention that TASO has used, and actually we've seen it in multiple other places, you don't want to rely on one, we could have 20% increase in outcome, and we could save hundreds of millions of dollars and get that same outcome. That's a pretty remarkable thing. That's what data quality and using data quality, but you have to use it at each level. Tertiary care is really important, but you have to use it down to the individual community. Now, that will require technology, although it doesn't require high technology necessarily. You can have innovation in technology that's relatively easy. There are handheld devices that can move this data around in a push and pull system from a community healthcare worker up to a global institution. And those are the kinds of systems we need to put in place, and we have the opportunity to do that in the same way that if I travel by train, as some of you do from New York to Washington, my cell phone call will drop 7 to 10 times. If I'm in a village in Africa, I can connect with almost anyone in the world because they're not retrofitting the system. They're actually building a new system. And so we have an opportunity to put a system in place that will actually be far more advanced than anything we have today because we don't have to retrofit. We have to be careful with that for two reasons. One, the systems in 5 years will look like phone poles and hard wires in 5 years that we think is innovation today. So you have to build into the system the opportunity for adaptability and change. And the second is we have to be systematic because I know a country in Africa, for example, that has 5 or 6 individual mechanisms for HIV reporting depending on which region or hospital you go to, which doesn't help the country very much. So how we build these systems has to be very intentional and very smart, and that's when you start getting people involved, it will happen. So I'm very happy to turn over the microphone to Joe because Novartis is a company that has been thinking creatively and innovatively. And one of your questions was, how can companies get involved? And the reality is companies are innovative institutions. I mean, they're actually created mostly by healthcare providers. Almost all the people who work for them are in health. They want to find innovation. So just as we're providing the incentives for delivery and incentive for outcomes, if we do that, there'll be plenty of incentive in the companies, and we will see innovation and leapfrogging. And if we focus on quality, if we focus on quality outcomes, I have no doubt the innovation will be there. And it's a pleasure to hand over to Joe, because I know he's been leading a lot of this at Novartis.
I'm going to head up there. Good afternoon. Today, health systems around the world are in a crisis. By the year 2050, for the first time in history, seniors over the age of 60 are going to outnumber children that are under the age of 15. And as the population continues to grow older and older, we know that it's going to increase demand for health care. Now, at the same time, chronic disease is going to increase to about 70% of the total disease burden by 2025. And as lifespans increase, these numbers are going to continue to rise, and this is going to put additional burden on healthcare spending and healthcare budgets all over the world. Now, the growing demand is coming at a time of incredible technology change, so we're able to now create breakthroughs in medicine that the world has never seen. And this is also going to increase demand for additional medicines, additional therapies, and overall health services. So today, our health systems are not yet ready to meet this challenge. The healthcare delivery model looks much like it did in the 1950s. Big hospitals that primarily focus on reactive care to people with acute illnesses. And if you look at what is spent in the world on health care, according to the Economist Intelligence Unit, health care spending reached $7.1 trillion in 2013. Now, people are living longer, and this number is just going to increase, and so the model isn't sustainable. That's why we need a new system, one where pharmaceutical companies, payers, healthcare providers, and governments are incented to work together to remove waste from the system and also improve the quality of care. So we have to shift from a system that is fundamentally transaction-focused to one that focuses on delivering a positive patient outcome. And if you look at healthcare delivery today, you're going to find that most systems don't know what they spend to deliver an outcome. They don't measure the outcome. They don't measure what they spend to deliver that outcome. So we can't get better. And where data does exist, we see huge variation across countries and across healthcare providers. For example, life expectancy across European countries is 9 years, believe it or not. That's a huge number. But it doesn't always correlate with spending. For example, more spending doesn't mean better results. For example, patients with heart failure in France, which is a country that is known for very good health care, and each hospital is paid the same amount for the same service, you can have a 20% variation in outcome, 20% higher chance of dying early in some regions compared with the national average. And data in the British Medical Journal shows that 50% of clinical interventions today are made without evidence of effectiveness. This means that our systems are paying a huge amount for interventions that we're not 100% sure are delivering a positive outcome. So how can we address this and shift away from the transaction and more towards the outcome? The first step is to systematically track interventions and outcomes for each patient in real-world practice. By combining this information with cost data, we could identify ways that we can really improve value in the system. We could identify and stop ineffective treatments. With the better evidence and clinical decision-making, we could make treatments that deliver a better outcome available to more patients. And by facilitating early intervention, we could prevent unnecessary disease progression and costly complications. Now, I believe that the pharmaceutical industry also has an important role to play in this transition. This is why over the past several years, Novartis has been moving away from the industry's traditional business of just selling pills towards an outcomes-based approach. So we're thinking beyond the pill and what else it takes to truly deliver a positive patient outcome. Let me give you a couple of examples. We're working on better diagnostics to make sure that only patients that have a very good chance of responding to a particular medicine will get that medicine. A good example is in breast cancer, where treatment success depends on a specific genetic mutation. And this is going to increase the positive chance of an outcome and decrease waste. We're also teaming up with tech companies to provide adherence support in the form of devices or apps or smart pills. These are intended to help patients take their medicine as prescribed by the physician and also deliver a positive outcome. We're also developing home monitoring solutions together with predictive analytical models that can allow physicians to intervene when the data says they should intervene. For example, with technology, we can predict acute heart failure episodes, and at times hospitalization can be prevented. Now, we also understand, though, that change is needed beyond just medicine. The system needs to change, and this is going to require a multi-stakeholder approach. That's why the European pharmaceutical industry has committed 100 million euros to a program called Big Data for Better Outcomes. This is a collaborative effort with the European Commission and stakeholders from health systems across Europe. In this program, we're going to shift from that transaction to the outcome by taking 3 specific steps. The first is defining and prioritizing an outcome, and then aligning with all the stakeholders on how to measure that outcome. Secondly, increasing access to data. Data is key. It drives the determination of the positive outcome and the interventions that deliver that. And then the third is increasing analytics, and that is to find what best works. We're going to have to look at the data and look at the interventions, get rid of the waste, and increase the activity in terms of what's working. Now, last week, we launched the first wave of projects under this program, one that focused on Alzheimer's disease and another that focuses on hematological malignancies. We're going to launch additional programs in cardiovascular disease, multiple sclerosis, and we hope that stakeholders throughout the system will join us as we move in this direction. Now, moving away from the current system to one that focuses on outcomes and value is a daunting challenge, but it can be met. And doing so is going to require leadership. It's going to require a multi-stakeholder approach, but it's the right thing to do for patients, for our healthcare systems, and also for our industry. Thank you very much.
So we have about half an hour for a panel discussion. And I think one of the fundamental questions that has been touched upon throughout the session has been description of a healthcare system in crisis. So Melvin, maybe if I turn to you first. Is there really a crisis in the healthcare system? And if so, what are your main concerns?
Well, starting from the Swedish perspective, I think that many of you know is that Sweden is ranking very highly when you look at the quality of the healthcare system. And still, in Sweden, we also have the perception that we are in a crisis. So what is really going on? I think that what people realize nowadays is that we are at the end of the line of the development of the current healthcare system. So we are on a turning point, and we are going towards a real big paradigm shift. And I think that creates the feeling of crisis. I think that makes people very unsure. So what I try to do is reassure on one hand the people that we are providing healthcare at a very high level, and at the same time make the change more rapidly than ever before. Because we're definitely aware of the fact that if we don't change it radically, we will not be able to provide the healthcare at a high level in the next 5 to 10 years.
Maybe turn to you again, Joe. Among the big pharma CEOs, I think you were the first to very explicitly state your conviction that this direction we've talked about today is the right one. What was it that convinced you that this is the right thing? And what has been the reaction among some of your peers?
One of the things that convinced me that this is the right thing is just looking at a 10-year view. And if you look at what's going to happen from a demographic standpoint and with the population, we're going to add 1 billion people to the Earth's planet. And if you just take historical algorithms and what that means for healthcare spending is going to double in the next 10 years. Well, healthcare spending can't double in the next 10 years. So to me, that's the crisis, in that if we don't do something, the system upon which we all rely is going to buckle under weight, and patients are going to go without the care that they need. So you can imagine this isn't the most popular of topics among pharmaceutical executives. However, if you think about a system that delivers on better health and the discovery and development of new drugs and what that's meant for medical practice, we're going to have to be part of this solution.
Thank you. I think one of the key themes that's also been through the discussion is we need to measure outcomes and we need to make it transparent. And Hartwig, you started your work at the Martini Clinic with outcome measurement. You built your registry in 1992. And you've described how you've shared the data where some are doing better than others. Now, initially, you said you didn't fire the guy who was better than you, which was, I think, nice of you. But I think I'm curious to hear, for those in the audience who are leaders of provider organizations, how has the transparency influenced the dialogue in the team? What were the challenges and how did you overcome it? And what is the spirit of the team today when you have your biannual meetings or twice a year meetings where you sit down and compare your individual results?
Well, before I answer it, the background was that we experienced so much benefit from our database. I give you an example. We sit together in the morning and some reports say from a patient that he would benefit from radiation. Somebody suddenly asks, does it really make sense not only to operate but in addition to radiate? Well, and then we go over next door to our biostatistician. I make it a little bit easier, of course, now. And 4 weeks later, he come up with our data and say that really in the past, those in this indication who has received additional radiation therapy had a big benefit. So on that background, we all experienced positive effects from our database. And maybe this background is necessary, that we have no ego problems when we meet every half year and get our results. And maybe this is an ideal world, but I would assume that every doctor with a little bit of empathy would be happy to improve. And one time I was a little bit better than the other in terms of certain criteria, and then I operate with each of them, and then they improved and they were happy. I'm not sure that answer really your question, but we experience a positive spirit with the database and the evaluation of the database.
Christina, you mentioned that there is a couple of hundred of organizations now reaching out to ICHOM to start measuring the ICHOM standards. And I think you mentioned also that some of them are also seeking advice for ICHOM. What is it they're struggling with? What kind of help is it they're asking ICHOM for to overcome the initial inertia of not having measured before?
I would say that very many ask because they have become interested in the framework and they would like to understand how can we start doing this in our organization. And what we have seen so far is that it's extremely important to have a driving force from the healthcare teams, that there is an interest from the clinicians. And when you have this kind of interest, you put outcomes as the goal of your organization. And when you do that, it's much easier to have the whole organization focus on moving forward towards the outcomes that matters most to the patients. So it's more about igniting the process and have someone who's actually would like to pilot it. So we see the most successful is actually the ones who can find a couple of pilots and start there. And it's often difficult, if you are not, of course, redoing your whole healthcare system, to start on a very broad base from the beginning.
Maybe to tie to that, Melvin, you are starting a series of projects. You mentioned redesigning the care pathway, and part of that is defining outcomes for those patient groups. What has been the reaction within the Karolinska University Hospital, which is, after all, a highly reputed organization with many strong-willed colleagues who think they are, or know they are, very high-performing on an international scale?
I think that one of the things that we haven't talked about, I think that data gathering, getting them transparent as possible is extremely important, not only to compare the data between several institutions, but also to get more engagement of the doctors and the nurses. And I think that's a general issue also at Karolinska, is that we see that there is a drop in engagement. And when we start talking about the real issues again, so what are the outcomes that you're measuring, what is the outcome that matters to a patient, and how can we improve that, then you see the engagement going up. And as you mentioned, doctors at institutions like Karolinska are highly competitive. So they really want to know their data, and they want to have an explanation why something is going better or something is not as good as the average. So in my mind and my experience, it really helps to get the engagement to a higher level within the organizations that we have.
Jonas, you described how you have used hospitals across Sweden as a test bed for a new type of clinical trials. When you hear Christina describe several hundred institutions now wanting to implement standardized outcome measurement, in a way you could say could be the starting point of a global registry for some of those conditions. Do you foresee that the clinical trials you have done on a national level could be done on a global level using the same approach and logic that you laid out and have done so eloquently in Sweden?
I think that's a very important question. We need to do it on a global level, or at least in a variety of countries. We're currently expanding the concept to the United States and to collaborate with other European countries. And I think it's extremely useful if we can have outcome measurements standardized. When I started in clinical research more than 20 years ago, I was told by a senior researcher from Oxford that if you only measure all-cause mortality, it's easy. It's comparable throughout the world. But it's not enough. We need, as pointed out previously, patient-reported outcome measurements also. We need to create value for the patients, and we need to have the data available for the physicians treating the patients. And I think to have healthcare records or clinical registers serving the data on a day-to-day basis, 24/7, online, as pointed out, not to the fire brigade, to the industry or to the government or something like that else. We need to have it available, and then we improve value for our patients. And if we then can compare between countries, and if we can do randomized clinical trials in a more facilitated way throughout countries, not only Scandinavia, but throughout Europe, it's amazing.
Mark, if I turn to you, you described how you're piloting efforts to measure outcome, and we identify that some do better than others, and you can learn from that and disseminate that knowledge to drive improvement. What do you see as the main barriers to scale this up, across diseases and across geographies? What will be innovations needed, or what will be investments needed, maybe by organizations such as yours or Gates or others, to enable this development to move faster?
The barrier is often the institutions we've created. So go back to the Tasso example. We went and found what they did. It was actually the community that figured out the solution. We just went and looked at it, right? The innovation and service delivery is, I think, vastly outpacing the innovation in technology. Yet we don't focus on that. So focusing, really seeing innovation as a service delivery opportunity is I think, hugely important. And then having technology that responds to that as well as helps drive it. Sharing things is not easy across institutions in countries from place to place, but some countries have done it extremely well. I mean, Ethiopia has a very specific system where each village meets once every 2 weeks with the number of villages, and then they meet once a month around, and it's the healthcare providers and the people around that bring forward things, and then they create new solutions and solve them. So the biggest challenge is probably shifting from a thought process of we will come up with the solution and bring it to you and you will implement it, to you come up with the solution and figure out how to do it and we'll support you to spread it across your region or your country. And that requires investments. Now, our model is rather unique. From a development agency, we basically provide resources to a country, and then the partners in the country, we don't have anyone in country. It's up to the partners in country, led by the country itself, to figure out how to use those resources. Often what gets lost is data and data management systems, because they need to buy antiretrovirals or anti-TB drugs, or they need to invest in some healthcare workers. So as we're trying to support people to use the data, the key thing will be having them understand and accept that this is a key investment for them. If we're actually creating systems or trying to build in systems that are basically reporting mechanisms, not use for patient care, it won't work. And that's a key thing we're all going to have to do. And that requires maybe some upfront investment, but if you're developing a handheld system that's just reporting, no one's going to use it. If it's additional to your clinical work, no one's going to use it. So we have to really get to the providers too and see what do they need and want. And that's challenging. And then we have to find the money to do it, which is even more challenging.
And that's an interesting link maybe to both Hartwig and to Jonas, because in your settings, in your institution and in the network, what you're describing, Mark, is a distributed innovation network, where innovation is not coming top down, being implemented, but actually clever colleagues figure out a new way of doing things, which leads to improvement, which can then be distributed and disseminated. Any concrete examples from the work that you've done? I think you laid out one colleague who was outstanding and beat everybody else. But maybe, Jonas, also from your side, the distributed innovation, where you can have 2 or 3 order of magnitude more innovators contributing to improvement than if you do it top down, which is what you described.
Well, I think one day there will be competition. If one society or one certification process, we are in Germany have 97 certified prostate cancer centers. If this certification, which in the past is based mainly on process management, control and audits, and you have to document that. If in the near future outcome data will be included and will be made transparent, then I think there will be a positive pressure of competition to other the breast cancer societies or whatever. And maybe one day you have to do it to survive and make your outcome data available and transparent. So that's what I hope, that there will be a pressure of competition in the future.
I think we need to empower the physicians and also the patients. Sorry. I mean, value is what is the driving force for both health is the driving force both for patients and for physicians. Just by making our registered data available and publicly transparent, no one wants to be second best. If you see that someone else is doing this job better, you will pursue a task to improve. And if you involve patients and also have patient-reported outcomes, which is important for patients, of course, then you improve the health and the health care. I mean, my colleagues, they really don't care about economics. They don't care about how many minutes per day is the operation room used, which is the old-fashioned way on how we organize healthcare. We want to treat our patients, we want them to be healthy, and the patients also want us to do that. So we need to shift that around. And if we measure outcomes instead of procedure measurements, we can shift that. And also, as pointed out by Joe, we need to sort out treatments that don't matter, that don't increase health. We have several of those still in healthcare.
So maybe a final question to the whole panel. We've had many years of a variety of healthcare reforms. We've had a number of different buzzwords that have been introduced into healthcare as the silver bullet or golden bullet to allow us to improve productivity. What is different with what's being presented here? Some say, well, value-based, that's another buzzword. And some say it's a consulting buzzword, which I hate when they say that. Because it's not, it came from somebody else. No, but why would this view be different? Why would we have more impact with this perspective than lean or other isms that have been circulating over the past 10, 20 years? Joe, you grab the mic.
Yeah, I think the thing that's different now is that we have a burning platform, right? If you look at what's going to happen with healthcare demand, if you're spending $7 trillion a year and we think that 25% is wasted, that's $1.5 trillion. So the funding that we need is right in front of us, but it won't happen unless we move to this, and that's what I think is different this time. There will be a need by governments, by payers, to force this change with all of us because of what's coming.
Yes, and I would like to follow up on that and say that this uneven quality, which is invisible to patients, to payers, and also to providers, will go away because it will finally be possible to compare the end result for the patient and to share best practices and learn from each other. And it will also put much more focus, as I mentioned, on the outcomes versus the processes. So you can really start understanding, which we have discussed here, what kind of activities and services provided do actually not contribute and give any value and could therefore be reduced or even eliminated, and which ones are the important to keep.
So from a global health perspective, if you look back 15 years ago and you asked anyone what were you doing in nutrition or health, someone would have said we're spending X amount of money. Literally. 15 years ago. Now you have to talk about results. Right? But those results, so we had this huge change in our thinking. The next change is to go from national average results to site-specific results so that we're actually looking at outcomes. And the reason I think it's going to happen is because we've made this big progress and everyone sees that we need to change again. And so we have a driving force for that change. But the other thing is the people on the ground are going to do it. So we can either support them or not. I mean, the TASOs, they're out doing it. I mean, they're changing, they're innovating. So we can either support them in that change and have a faster change, or they're going to do it anyway, and we're all going to be kind of irrelevant in a lot of ways. And maybe we should be. But the change is right there. We just have to seize it and then be smart about how we do it. And the great thing is these people are empowered. The individual healthcare workers are now empowered. They're demanding things. The patients are demanding things. So we can see that change. But we have to actually do it, which means changing how we think.
One short remark. I don't see it as either or. To have progress in healthcare and improving healthcare, we still need the old elements, science, for example, to identify what you mentioned by genome analysis, one day the responders of an expensive medicine. Don't treat everyone with all the side effects and the cost. We still need management control, audits, looking if there are high standards. We still need it. But the new and exciting thing is we should add outcome analysis and make it transparent and comparable and with the eyes of the patients. That's, I think, it should not mean skip all the old things, just add this new aspect.
I think all is almost said, but to summarize it, I think the burning platform, the transparency, the co-creation, these are essential elements. And the thing that we really need to do is talk about the issues that matter. And I think that we still have organizations with too much control, too much KPIs that don't make sense. And we have to decrease that in order to unleash the creative power of our co-workers.
And I think that maybe that closing remark, I think the key thing that comes across is if we focus on what matters to patients, we will get the staff engagement, we'll get the passion, the problem solving, all that, which today is not leveraged properly. Staff is often seen as the problem. You need to control the doctors and nurses because they're wasting too much money. If you engage them to solve the problem, which is healthcare productivity, better outcomes for dollars spent, they will mobilize all their problem-solving capabilities, and we can move forward. Thank you so much. Thank you to the panel, and thanks to the audience for listening to us. Thanks.